So it's a great honor to be here today, particularly giving the David Parke lecture. There's a connection here in that while I never had the opportunity to meet this David Parke, I've had the opportunity to work with his son, David Parke, and his grandson, Will Parke. David Parke, obviously, is a very well-known and illustrious retina specialist and CEO of the American Academy of Ophthalmology. But Will Parke was one of our residents at Bascom Palmer and one of our retina fellows, and now in practice in Minneapolis. And Steve Getty, who's here as director of our residency, can say wonderful things about Will. But it's quite a family, and it's a great honor to be here today to give a lecture on his namesake. So this is a very important year in optical coherence tomography. It's the 25th anniversary of OCT. And you're going to hear later a talk by Ed Buckley about disruptive technologies. Well, this has really been quite a disruptive technology. It's changed the way we practice retina. And I've had the opportunity since my early years at Mass Eye and Ear, starting in '91, to see this technology evolve first in Boston and then through Zeiss, and now spreading through a number of companies throughout the world. And for the residents in the room, when this technology started, no one thought it had a chance. We didn't think that it could really show us what we needed to see in the back of the eye. But the technology evolved, and in the early 2000s, we had time domain, and then in the mid-2000s, we had spectral domain. And what I'm going to share with you today is swept source OCT. And I feel we're at the point now with OCT, swept source OCT, and OCT angiography like we were back in the 2000s. People are asking the question, do we really need it? Is it going to change the way we practice medicine? And this is another revolution in imaging of retinal diseases. Just like OCT really decreased our utilization of dye-based angiography, I think with swept source OCT and OCT angiography, dye-based angiography for most retinal indications is dead. And I'm going to tell you why in just a few minutes. But let me just acknowledge first, I don't do any of this work alone. I have a bunch of fellows and retina colleagues at Bascom Palmer, in particular Giovanni Gregori, who came up with a lot of the algorithms that I'm going to share with you and are on the commercial instrument, as well as some collaborators, the University of Washington, Seattle, Ricky Wang and Qinshin Zhang, who are really fantastic engineers and scientists, and the Carl Zeiss Meditech engineers and scientists. We've worked closely with them for 15 years. They're amazing people, and they really work hard to improve the technology every day. And we do have a research agreement with Carl Zeiss Meditech, and there are licensing agreements between University of Miami and Carl Zeiss Meditech. So, age-related macular degeneration. Now, we're used to pretty typical imaging technologies for OCT, color fundus imaging, autofluorescence, infrared reflectance. We do dye-based angiography. Can you hear me with this or no? Testing, yep. We do dye-based angiography for wet AMD, and we do other reflectance imaging for dry AMD. But moving forward, all we're going to need is OCT and OCT angiography for macular degeneration. And macular degeneration really is the 800-pound gorilla when it comes to macular diseases. Diabetes, yes, but AMD is where the true value of OCT angiography will be appreciated. So what's the best OCT imaging technology? And I'm going to introduce you to swept source. So many of you know about spectral domain. It has a wavelength of 840 nanometers. Well, swept source was developed for the back of the eye by Jim Fujimoto, the father of OCT at MIT. And the images are processed the same way using Fourier domain technology, but it's faster. It's up to 10 times faster than spectral domain OCT. The scanning rate, just to give you an idea of how it's progressed, the time domain was 600 A scans per second. Swept source OCT is up to 400,000 A scans per second. It penetrates better into the back of the eye with less sensitivity roll-off. And the wavelength's a little bit longer, and that's why it penetrates better. It's 1050 nanometers, while spectral domain is 840. So here's a cartoon. I've simplified the technology. We use a superluminescent diode as the light source. It's a broadband light source. And we replace that with a tunable laser with a center wavelength of 1050 nanometer. And we replace the spectrometer with an individual detector. Why this should be faster, I can't explain it. But the engineers can tell you it's just a faster technology that allows you to scan at a much higher rate. But everything else is the same. The image processing is essentially the same. You're just getting the imaging faster than you would normally with spectral domain. And this is the prototype that our prototype scans at 100,000 A scans per second. I collaborate with Jim Fujimoto. His is the instrument that everyone covets. It scans at 400,000 A scans per second. But the goal is to do with this instrument and the next generation, which scans at 200,000, what he can do with the 400,000 instrument. So faster scanning rates increases your imaging power. So in 3 to 4 seconds, you acquire 100,000 A scans to 300,000 A scans per second, okay? So what you can do with this is you can image large areas or very small areas. So we're going to talk about small area imaging and the diseases that enables you to study, and large area imaging. That's the next talk this morning. So let's talk about the smaller area. And the best disease to look at with the small area imaging is a condition that we thought was pretty rare, called Macular Telengiectasia Type 2. But it turns out it's just not that rare. For those of you in the audience, for the residents in particular, this is a fascinating disease. I don't think you can see it too well, but it's a disease that starts on the temporal edge of the fovea, and you can see it by abnormal vasculature. And Fluorescein shows you this abnormal vasculature by leakage here. And on OCT, structural OCT scans, you can see it as these little cystic changes, this draping of the ILM over these cavities, and disruption in the outer retina, in the internal limit, in the inner segment, outer segment, ellipsoid zone region. And as the disease progresses, it becomes more obvious. You get leakage all the way around. And here you get these cavities in the ISOS ellipsoid zone and the inner retina draping here. And this is pathognomonic of macular telangiectasia type 2. And as the disease progresses, you get pigment deposition, crystals, and you can see significant atrophy here in the retina. And the leakage, it's hard to tell the severity of the disease by the leakage, okay? And sometimes you develop subretinal neovascularization. Now, we thought this was subretinal neovascularization based on all the imaging we had done over the years. And OCT shows us this area because you get increased thickening of the retinal thickness map here. The only time you get that in MacTel is when there's neovascularization. So there's a project called the MacTel Project, and the MacTel Project is an international collaborative effort to find a solution to this problem. It was started out of Australia, a wealthy family that has macular telangiectasia type 2, and now it has spread globally. We're part of this project, and we have 95 patients with macular telangiectasia 2. There are about 1,200 identified worldwide with 44 family members. It's a combination therapy and genetics study. And we've done OCT angiographic imaging on 45 of these subjects, 87 eyes, and 10 of them had neovascularization. And we started in this study about the same time that we were able to have access to OCT angiography. So what I want to do is just quickly explain the basic premise of OCT angiography, because it uses OCT scanning techniques, but in a slightly different manner. So here we're imaging a 3x3 area of the central macula. And in this case, there's 300 A scans at each B scan along the 3 millimeter distance. So each A scan is separated by 10 microns. And then there are 300 B scan positions in the Y dimension, all right? And the key to this technique is each of the B scans is repeated 4 times in the exact same location. And it's done, this is performed over and over and over for each of the B scans positions. You acquire a lot of A scans and a lot of B scans, and this can only be done if you scan quickly. So 360,000 A scans in 4 to 5 seconds. And the way it works is those clusters of 4, the B scans, they're compared. And any change that occurs when they're rapidly performed in the exact same position, any change must be due to motion, because the red blood cells are highly reflective, and anything that changes in each of those 4 clusters must be due to red blood cell flow. And using the OMAG algorithm, which uses intensity and phase information that Ricky Wang came up with at the University of Washington, Seattle, you can get a flow B scan. All these signals here are flowing erythrocytes. And when you put them together, you can put these B scans together and you can have the flow represented as color, and then you can have an en face representation. Now you're looking at that 3 by 3, and everything that you see here is flow. And you get an unbelievable depiction of the retinal microvasculature. So what's really neat about this technology is using the mathematical algorithms that initially Giovanni Gregori came up with, we can slice and dice the retina into different layers. So here we can look at the inner retinal layer, the superficial retinal vasculature, the middle retinal layer, what they call the deep retinal circulation, the outer retina, which is avascular. Then you can look at this layer that encompasses the outer retina to the choriocapillaris, very important layer. We call this the ORC layer. But this is where most of the action occurs, particularly in macular diseases, between the outer retina and the choriocapillaris. Then you have the choriocapillaris, and you can have the choreo. This is the first time we've ever been able to actually image in a living subject the choriocapillaris. And it opens up a whole new world of looking at macular diseases. But this ORC layer, this slab between the outer retina and the choriocapillaris is really important. Just to emphasize, we take this area here, we remove what's in the inner aspect of the retina, all the circulation. We remove everything up to the choriocapillaris, and we just show here that layer. But you say, wait a second, I see retinal vessels in that layer. There's a very important concept that you need to understand. It's called the projection artifact. What you're seeing is the light passing through the retinal vessels and reflecting off of the retinal pigment epithelium. So you get a motion artifact where those retinal vessels are projected onto a screen, much like light is projected here onto a screen, okay? And those are artifacts. Sometimes they're useful. Most of the time, they're a nuisance, okay? But I'm going to show you the techniques that we can use now to get rid of those artifacts, okay? So we've published extensively on just the normal algorithm as well as macular telangiectasia type 2. And this is what you see in a normal patient. What you have here is the superficial, the deep retinal circulation, the outer, and the composite color image in which different layers are color-coded, okay? So here's an early case of macular telangiectasia type 2. Superficial, you can see some abnormalities here. The middle retinal layers where the action is. The outer retina, not much going on, but let's look here, okay? This is the Fluorescein angiogram here, lots of leakage. This area blown up, you see the abnormality. And now you can look at the OCT angiography, and it represents this abnormality beautiful without it being obscured by the leakage. Okay? Here's another case, a little more advanced. Here we have the temporal edge of the fovea, slightly abnormal. A little more abnormalities extending all the way around with telangiectasis. The outer retina now has some circulation because it's collapsing. All right? Let's look at this area. Here's the Fluorescein blown up, and here's the OCT angiography showing the area beautifully. You actually get more detail of the retinal microvasculature than you do with Fluorescein angiography. A little more advanced case. Here we have anastomoses going on between the deep and the superficial retinal circulation in the outer retina. This is what the Fluorescein looks like. And now we can see color-coded anastomoses between the deep retinal circulation and the superficial retinal circulation. Much greater detail, more anastomoses, more advanced disease, communication between all the retinal layers here. Here's the Fluorescein, here's the OCT angiography, and now an even more advanced case where all the retinal vessels are being dragged temporally, the anastomoses, deep in the retina, Fluorescein, much greater detail with OCT angiography. We say that's great, but what are you going to do for this patient anyhow? This patient, you're just going to watch the patient. There's nothing to do. It's pretty, right? So let's talk about neovascularization. We can do something about neovascularization. So here we have a patient that comes in 2013, macular telangiectasia, 2040, 2080. You can see on the autofluorescence there's a defect temporally in both eyes. All right? This patient then comes in. This is what the OCT looks like, totally normal, no swelling. This is what the fluorescein looks like. A lot of leakage, but a question for the residents: why is it there's all this leakage, but the OCT looks pretty normal? Where's the fluid going? We'll get back to that. That's a test question for you. Right. So here's the patient in 2013, comes in a year later. We get increased thickening here. There's neovascularization under the retina. There's the thickening on the OCT macular thickness map. Okay. The retina doesn't show much, just a lot of distorted vessels, anastomoses deep into the retina, but no neovascularization. But there's the neovascularization right there, colored pink. Pink is under the RPE into the choriocapillaris. capillaris. Right? Here's the fluorescein. There's the neovascularization. You don't see it in the retina. You only see it under the retina. And here's that ORC slab. There's the neovascularization. We can now slice and dice the different layers. And those retinal projection artifacts, we can get rid of them now mathematically. It's very easy. This is what it looks like on top of the entire choroid. And here's the color-coded map. It's beautiful. All this information can be acquired in 4 to 5 seconds. Amazing. And then the images are just sliced and diced different ways. There's the neovascularization. So now when you look at the fluorescein and you look at that ORC slab, you can see the lesion beautifully. Right? So this patient had to be treated on the outside. I couldn't treat this patient. This patient was undertreated for a year, only 3 injections with Avastin. This is what happened. The lesion got worse. The vision went from 26/40 to count fingers at 2 feet. The retinal vessels are mightily distorted and confused, but what's happened to the neovascularization? There it is. You don't see it on the retinal microvascular maps, but you do see it beautifully on the ORC slab, okay? The artifact removal on top of the choroid and now color-coded. And now as you look at this over time, you can see the fluorescein is represented beautifully with the ORC slab, right? There's the lesion. And now over time, you can follow the patient without fluorescein angiography, without injection, easily done in 4 to 5 seconds. And now this fascinating case of macular telangiectasia that came in. This is a patient, 20/50, 20/20 vision, seen in July 2014. This is what the patient looked like in 2014. Came in 6 months later, fluid, thickening, okay? And then when you look on fluorescein, there's a lot of leakage, but you don't see the neovascularization, a lot of confused microvasculature, right? But on ICG, you see the neovascularization here beautifully, right? And what you also see on ICG is it's not subretinal neovascularization. It's choroidal neovascularization, anastomosing with the retinal circulation, right? And here's that ORC slab, shows it beautifully with the anastomoses, with the projection artifact removal, and with the choroid composite image, right? You can actually see a communication here between these 2 lesions by the OCT angiography. I don't know if you can just see it in the audience, but it's there. So this is just a remarkable way to follow these patients. And this patient I did treat with 1 bevacizumab, 2 bevacizumabs, 3, went from 2400 to 2040. And when you look at the retina, you can see the changes. Just look at this middle retina slab here. You can see the telangiectatic changes go away, the retinal caliber diameter changes. But what's going on with the neovascularization? This is what's going on. It's just it prunes back and prunes back. But they don't go away, and that's a central theme with OCT angiography. These neovascular membranes are not going away. We're just controlling the exudation. So this patient ended up doing well, but unfortunately moved out of the area after this visit. Okay, so is this just a research tool, or are we really going to incorporate this into our clinical practice? The questions that I get are, I don't use much fluorescein, I don't use much ICG. Why should I be spending the time, the effort, and the cost for OCT angiography? How is it going to help my patient management? And I've been thinking a lot about this because there's 2 broad areas. One is you're going to identify patients earlier that need your attention. For the first time, we can see these blood vessels coming long before they cause exudation. And even when we're actively managing patients, we're going to use OCT angiography to control how we manage them and get better outcomes. Let me show you a couple recent cases. So this is a patient, 85-year-old man, who's been getting multiple anti-VEGF injections in the right eye and comes in suddenly, the left eye, with decreased vision. So here's the patient, December of 2015, this past December, 2025 vision. You see drusen, no exudation, the map looks good. And suddenly the patient comes back in 3 weeks later. Look at this, massive exudation, fluid. Do you think this blood vessel just popped up suddenly and grew like that and started exuding in a period of 3 weeks? I don't think so. I think the culprit is right there, but we just don't see it yet. How about another patient, a 77-year-old, multiple injections in the right eye, left eye. In January, came in, boom, vision was worse. This is what the patient looked like. Looks like typical drusen, right? Nothing too concerning. Watch, amps or grid, monitor your vision. Patient comes in 3 weeks later, look at that. The vision's still pretty good, but do you think this blood vessel just popped up suddenly? How about this other patient, 89-year-old, multiple injections in the right eye. Left eye supposedly was stable. Here it is now. What I love about this case is there's a little PED here. That PED, I can't prove it to you, but I'm sure that PED was the neovascular membrane that was just hanging out there. All right? And then the patient came in 6 weeks later with exudation. Wouldn't you like to know, when a patient comes in with dry macular degeneration, wouldn't you like to know who's a ticking time bomb and who isn't? All right? So, back in 1973, Shirley Sarks published a histopathologic study of dry AMD eyes, and she found that there were these neovascular complexes hiding under drusen that no one was aware of. And in 77, Dick Green published a similar paper, these non-exudative neovascular lesions. And back in 97, there was this study where they treated patients in one eye. They were giving laser to one eye for wet AMD. And the fellow eye, the dry eye, they were observing, and they performed ICG angiography. And they did it in 124 consecutive patients, and they found these plaques, ICG plaques in 11 eyes, about 9% of eyes. They followed them, and 64% of these plaques converted to exudative disease. So we've known for a long time, using ICG, that we could identify these lesions. And David Geyer in Yanuzzi's group looked at 432 consecutive eyes in 98 and found abnormal ICG findings in 11%. In 96 eyes, he followed them, and in those eyes with plaques, they converted about 16% a year to exudative disease. So we had the power to know who was likely to convert, but we didn't do it because we don't routinely perform ICG angiography because it's expensive, it's invasive, there's systemic risks, it's time-consuming, it's resource-intensive, and we don't get paid for it, okay? So we don't do it. But if we really appreciated that we could have found those lesions, perhaps we should have been doing it and looking for them. But now we don't have to do it because we have OCT angiography. And I just want to emphasize this ORC slab. Remember, we're getting rid of most of the retina and most of the choroidal circulation. We're just looking at this thin layer, all right? So you heard I was a resident in OBGYN, okay? Never finished. I was a resident. Then I go into retina. I'm an ophthalmology. I go into retina, train as a vitreoretinal surgeon. Then I become a macular disease expert. Now I become an expert of this region. This is my expertise. This little slab, that's how my career has been focused down. Right? And this is the area. This is what we're going to look at. Right? So here's the strategy. Perform fluorescein and ICG on patients getting treated for wet AMD in one eye. And let's look at the fellow eye. Identify eyes with intermediate dry AMD that have these plaques, and then ask the question, does OCT angiography identify the neovascularization in those eyes with plaques? Okay? This paper, June 2016, out this month in Ophthalmology. And this is what we found. We looked at 11 patients, 3 eyes with dry AMD and had the plaques. We saw the CNV in all those eyes, okay? And we did not see CNV in eyes that did not have ICG abnormalities. And now we have a much larger study underway with over 100 patients, seeing how frequently we find these plaques using OCT angiography and what their progression is. So here's one of the cases. This is a patient, you'd come in, you'd say dry macular degeneration. Some reticular pseudodrusen in here, all right? This is the OCT. This is the telltale sign. This low-lying pigment epithelial detachment. We would have thought this was a drusen or coalescent drusen, but no, this is a neovascular lesion that just isn't leaking yet. Right? Here's the fluorescein. Nothing. Totally dry. Here's the ICG. That's what we call a plaque. All right? This is that plaque blown up to the 3 by 3 millimeter central area. Let's look at a B scan through this region. All right? And here's the color-coded flow. And what you can appreciate here is that there's pink under the RPE here above Brooks membrane. That shouldn't be there. Remember, all the circulation is below Brooks membrane and above the RPE. Nothing should be between the RPE and Brooks membrane. And notice the center area is spared. Okay? So here's the total retinal flow, nothing seen there. Here's the composite ORC slab with the choroid combined, the color-coded slab. Here's the entire ORC slab with the projection artifact. And here we've removed the projection artifact. That's the neovascular lesion. All right? And that's how it compares to the plaque. All right? And now we follow it over time, and this patient's been followed for 9 months, and it's slowly growing. But it hasn't progressed to exudation yet. Maybe it won't. Maybe it will. But at least we know this is a high-risk patient that needs to be followed closely. Here's another case. Dry macular degeneration, just some drusen. You can see the drusen here. Pretty benign looking. Not so benign. Here's the fluorescein, nothing. Here's the ICG, there's a plaque. All right? Here it is blown up. These aren't drusen. These are vascularized PEDs. And you can see the pink inside. Right? There's a layer of neovascularization here. All right? And there it is. It's a beautiful neovascular complex. Here it is with the projection artifacts, without the projection artifacts. And you can see how well it lines up with the plaque. And we've been following this for a year now. And it's grown, but it's not leaking. So what should we do about these lesions? We can talk about it. Here's another case. This patient had a little oozing on fluorescein that we didn't really appreciate on the OCT. There's a plaque on the ICG. Here it is. Here's the lesion. There's the flow. Borders are similar. And this is what the lesion looks like. Big flower-like neovascular complex. And this one matches up nicely with the plaque. And it's growing slowly over a period of 9 months as well. So now we know that patients with dry AMD harbor these neovascular lesions, and they grow slowly, and they grow slowly, and then suddenly they present themselves with exudation and vision loss. What's going on? What can we do to stop this from progressing? Well, we don't know, but we're coining this new term that we're going to be using called non-exudative neovascular intermediate AMD, because not all neovascularization is exudative, and we clearly need larger studies, and those studies are underway. We need to know the incidence, the prevalence, the natural history. Are there any changes that are predictive of what's going to happen next, okay? So we can prepare our patients, or maybe even intervene and start treating at an earlier stage. They need close follow-up, and maybe these home monitoring techniques, whether it's Digicite or Foresee, the Nortel home monitoring, is ideal for patients like these. How are we doing for time? 5 minutes, okay. So now let me just show you this great case about early detection, how it helps you with the management of wet AMD. So this is a patient that came in 20/20, 20/25 vision. This eye is getting lots of injections. This eye has never gotten an injection. This is what the autofluorescence in infrared looks like. This eye has lots of injections. This eye, no no injections yet, a little PED here. This is the fibrovascular PED in the left eye, little PED here, okay? So the left eye is getting injected, and we watch the right eye and watch what happens to the right eye. 7 weeks later, 2020, 2 weeks after that, still 2025, 2030 now, lots of leakage. Resident, what kind of lesion is this? Pigment epithelial detachment, cystic maculopathy overlying on PED. This is a RAP lesion, retinal angiomatous proliferation, type 3. Okay, this is what it looks like on OCT angiography. It actually grows in the retina, right? This is the lesion growing. Okay, this is what it looks like on fluorescein. The day we treat it, there's the leakage. ICG, you get a hot spot, okay? And now when we look at this area, there it is, right there, the area leaking in the inner part of the retina. It's an angioma, all right? So this is what it looks like. Here's the flow. There's the communication to the sub-RPE space from the retina. It's a primary retinal disease. And we treat, comes back 4 weeks later, beautiful, 2025. Treat, 4 weeks later, 2020. The flow is diminishing. Treat, comes back in 6 weeks later, 2020. Comes back in 6 weeks later, 2020, doing great. So we're going to extend to 8 weeks, all right? Now, let's give another perspective here. This is the en face representation of the ORC slab, the projection artifacts. There's the lesion. We're just looking under the RPE here. Projection artifacts, okay? We're now going to take the same information and remove the choroid. This is the slab. There's the lesion down there, just communicating under the RPE. Okay, there it is. Now what we're going to do is remove the projection artifact. So we're just looking at this little area of flow under the RPE right here. Okay, injected with Eylea. Let's see what happens. 4 weeks, comes back 6 weeks later, comes back 6 weeks later, and now we extend to 8 weeks because the patient's doing so well on structural OCT. Okay, comes in 8 weeks later. Notice the flow here. It's different under the RPE. Okay, there was something cooking back here that was different than what was here. Look at that. In 8 weeks, a whole new lesion popped up under the RPE, a type 1 neovascular complex. Okay? And we inject now, instead of extending now further than 8 weeks, even though the patient was doing well, we treat every month. And look what happens. This patient's still 20/20. But look at that neovascular complex that's growing under the retinal pigment epithelium. We would have never known it was there. And if we had extended this patient further than 8 weeks, it would have been a disaster, right? So this is the progression of that lesion that was totally separate from the original RAP lesion, okay? So what's nice, I'll talk about this afternoon using en face imaging to follow atrophy. But you can actually see the communication here with the type 1 lesion going to the type 3 lesion, all right? And this patient's doing great. There's no exudation, but we know what's under the surface now. And let me just show you the other eye quickly. This eye had been treated a lot, and we extended this eye to 8 weeks too because it was doing so well. And this is what happened when we extended to 8 weeks. It went from this, a little fluid, and now a monster grew in the back of the eye. We can see things now that we never saw before. But this eye responded well. We treated and it pruned back. So now as we look at the progression here, it gets worse, but then we're able to control it by monthly dosing. And this is what the patient looks like now, doing very well at 20/30. So in summary, OCT angiography is not just a research tool. We demonstrated the proof of concept in macular telangiectasia type 2 because we could focus on the center part of the macula. But for AMD, it's going to be useful for every stage of the disease. And I think it's better than fluorescein angiography and certainly as good as ICG angiography. Thank you very much.
Thanks, Dr. Rosenfeld, for outstanding lecture. Yep. Questions? Dr. Weiss? The question is, have you looked at anti-PDGF with OCT angiogram?
So right now, anti-PDGF, so the theory behind platelet-derived growth factor inhibitors is that you're going to prevent the growth of the neovascularization, and you might actually get regression of the neovascularization. Currently, OCT angiography is not part of the ongoing phase 3 studies. Praveen Duggal has limited experience with spectral domain OCT angiography, but he's not been able to show regression of the lesion. And this is going to be a whole area of investigation once the drug becomes available. And I think you're going to need swept source OCT to really see it. I didn't get into the details of spectral domain versus swept source. Looking at these lesions, we're doing a study now. But spectral domain, you can see them, but a lot of times they're not clear, no matter what platform you use. You know they're there, but with swept source, you can really see it. So I won't believe any of the data till we can look with swept source OCT angiography with the PDGF inhibitors.
Yes.
Okay. So swept source technology is evolving now. There's only 2 instruments that are going to be available. Topcon has a swept source instrument, but it doesn't have the algorithms or the imaging capability as the Zeiss. Zeiss is doing something very interesting. They've never done this before. In fact, I think this is novel for the imaging community. They are going to be producing the swept source instrument, but it's going to be a high-end instrument for people that want to do research. And you're going to be able to buy into the platform. And what's so interesting is this technology isn't holding static. The lasers are getting better, the scanning speeds are getting better, the algorithms are getting better, and you're going to be able to buy the platform, and it's going to include all the upgrades, much like buying a cell phone, and all the software and the hardware upgrades come along with it. That's the future, because this technology is evolving so quickly. So right now, this is all going to happen within the next few months. These instruments will be available for high-end users. And like most of cutting-edge technology, it's not going to be widely available for a few years, but it's going to be available, all right? And I think you need to enter this market with the understanding that you're going to need to upgrade, much like your cell phone, you're going to need to upgrade every few years. I'm sorry, but technology just doesn't hold still.
Thank you. Yes. Dr. Lesser?
Yeah.
So the question is, does OCT angiography does anything for acute macular neuroretinopathy?
So David Seraf has really focused in on this middle maculopathy phenomenon, and that's the deep retinal circulation, or the middle retinal part of the circulation. But my colleague, Janet Davis and Tom Albini, are having a lot of fun looking at different uveitic processes. And we just submitted a paper looking at MUDES. And it turns out that, at least I always thought MUDES was a disease of the choriocapillaris RPE. But it turns out that the choriocapillaris is totally intact in MUDES. All right? The retinal circulation is totally intact. This is a disease of the photoreceptor RPE complex, and it doesn't involve any abnormality to the microvasculature. What's interesting about acute macular neuroretinopathy, we just had a couple cases where we looked at, we can't find any vascular abnormality in that disease. So it's very different than middle maculopathy. Macular neuroretinopathy is a non-vascular disease, at least we think from our preliminary analysis. But that's a whole other area of investigation, particularly the wide field, which I'll talk about this afternoon. The wide field OCT is particularly useful for uveitic processes because it involves so much more of the retina. So it's an area of investigation.
Dr. Roca?
Why, if this is at a deeper layer, is somebody not investigating giving this intravascularly? You know, either threading up, you know, the carotids or...
If you remember, I started giving Avastin intravascularly. I gave high-dose systemic Avastin, the same doses we use for cancer therapy. That was how I started. And to this day, my patients who got the intravascular Avastin swear they did better with intravascular Avastin, and they were quiescent for months and months and months. Personally, I think systemic administration is a great idea. The problem is These drugs have side effects. Everyone worries about a dose of avastin, Lucentis, or Eylea. That's 1,000 times lower than the systemic dose, causing the possibility of thromboembolic events. Imagine the kind of risk you would have if you were marinating these patients with an anti-angiogenic factor. So the problem is drugs that get into the retina, okay, probably aren't going well into the choroid. If you want to deliver a drug into the choroid, you need either transchoroidal or systemic delivery. And whenever you start talking systemic, you're talking side effects, and we don't have a good way yet. There's a needle from Clearside that delivers drug to the suprachoroidal space, but a lot of that drug gets washed out right away. We don't really have a good way to deliver the drug where we want to deliver it in most of these neovascular diseases. But you're absolutely right. Systemic delivery is probably the best way to deliver the drug.
Thank you, Dr. Rosenfeld. And we have an award for Dr. Rosenfeld, the David Parke Award that reads the 2016 CSEP David W. Parke, MD lecture recipient, Dr. Phillip Jacob Rosenfeld, recognizing your lifelong journey of excellence, humanitarian efforts, and leadership in medicine.
Thank you. Hold it like this. Pictures.